Hi, everyone. Thank you very for the kind introduction. Thank you, Akoya, for having me here today to share our work, like the work that we do in our lab. So as I already mentioned, I'm a pathologist. I'm very passionate about pathology as well. And today I'm going to share our work in the assessment of tumor immune microenvironment in pancreatic cancer using tissue-based spatial analysis. Yeah, so this is the outline of my talk today. So why pancreatic cancer? So pancreatic cancer is unfortunately a disease that is not uncommon. And when I talk about pancreatic cancer, I refer to its most common type, which is pancreatic ductal adenocarcinoma, PDAC, which account for about 90% of all pancreatic cancer. And PDAC is the third leading cause of cancer-related death in the United States. So from the left to right, this diagram shows the natural course of cancer in general, where the appearance of symptoms is followed by the diagnosis. Then this will lead to the treatment choice and treatment regimen. And if the treatment is effective, we have a good response. Otherwise, we have disease progression. But why pancreatic cancer is so challenging? First, because we have challenges in each of these steps. First, pancreatic cancer has usually a late onset of symptoms. So when the patient, at the moment that the patient is diagnosed, the disease has already progressed. The other thing is that although there are these precancerous lesions in pancreatic cancer are very common, very frequent, they are very difficult to visualize. They cannot be visualized by CT scan or MRI. So, in addition, we also have limited treatment options and relatively low response rate to this treatment. So, with that, we have just a modest improvement in survival. However, there have been many efforts to make pancreatic cancer a curable disease. So right now, we've been working a lot on this early detection, so trying to get these precancerous lesions before it really becomes a pancreatic cancer. Improve tumor characterization, and with that, we can then work more focused on precision medicine with the ultimate goal of improving survival. And this is the focus of my talk today. So there is also another challenge in pancreatic cancer. As with most solid tumors, there are now certain genomic biomarkers that can be used to select therapy, as seen here on this table. However, the majority of these occur only occasionally. And although tumors here that are defective in homologous recombination represent the biggest potential class of targetable tumors, clinical sequencing techniques frequently fail in the clinical practice to detect these cases. So in general, only around 15% of the tumors are targetable. And in the top of that, immunotherapy has not too much effect on pancreatic cancer. So there is almost no space for PD-L1 testings, for example. So if there is not so much genomic targetable therapies for these cancers, we need to look elsewhere. So that's why we started looking at the tumor immune microenvironment. So pancreatic cancer is a complex system, and this figure here represents cancer cells as part of this large microenvironment that is composed of several cell types, vessels, and other components. So this environment, the tumor immune microenvironment, is responsible for supporting cancer cells. And there is a bilateral relationship between cancer and microenvironment. So the cancer can affect how the microenvironment works, as well as the microenvironment can affect how tumor progress and growth. Immune cells are part of this tumor microenvironment, and they can have a pro and anti-tumor effect in the tumor immune microenvironment. Beyond only densities, so immune cells are spatially organized as well, and I'm going to show this on the result of my work. So knowledge of this system can assist in design of better therapies. But as you know, there are other people that have been studied the pancreatic cancer microenvironment. However, many of these groups used less sensitive techniques or using techniques that lost spatial context. So we started exploring the tumor immune microenvironment in upfront resected cancers using multiplex immunofluorescence. So in a work performed by Sarah Varinen, which was a postdoc in our lab, she found that macrophages are one of the most common cell types in pancreatic cancer. However, surprisingly, this population did not harbor prognostic signification in pancreatic cancer. However, she did also notice something different, that M1 and M2-like macrophages, as you know, M1-like macrophage has an anti-tumor effect, and M2-like macrophages have a pro-tumor effect. So she found that these populations are differentially located in the stroma. And as you can see here, for using this mathematical method named G-cross function that assess the probability of colocalization between immune and tumor cells, M2 polarized macrophages are further from tumor than M1 polarized macrophage. So higher the value here on the y-axis on figure C, greater the probability of colocalization. So M1 polarized macrophages are closer to tumor cells than M2 polarized macrophages. However, she also found that this has prognostic signification. So greater M2 macrophages usually are further from tumor. However, when they are closer to tumor, they harbor a worse prognosis. And this was just able because this analysis was just able because we had single cell resolution and spatially resolved analysis. So then after these observations in mind, we sought to update our analysis of primary pancreatic cancer and also including more panels to then assess the tumor immune microenvironment. And at this time, we also made sure to include neoadjuvant treated tumors. So we analyzed upfront resected and compared with neoadjuvant treated tumors. For this analysis, we assessed around 300 cases using these 3 panels that allowed us to identify T-cell subsets and T-cell population and the main subsets, regulatory effector, memory or naive T-cells, macrophage polarization status across M1, M2 spectrum, and myeloid cell subsets that allowed us to identify monocytes and granulocytes, maturation, and also suppressive potential by expression of ARGDASE1. So having generated spatially resolved immune cell data from all cases, we then had main questions to answer. First, how many of these cells we had, so we were able to assess density. In addition, where these cells were located, in which compartment, in the tumor epithelium or stroma. Third question, how further they were from tumor. And finally, if the cells were mostly localized in the tumor periphery or invasive edge. Tumor center or invasive edge, and that accounting for heterogeneity. So here is the overall immune cell landscape for these upfront resected cases. So overall, the immune cell density varies greatly, but the median is close to 1,000 cells per square millimeter. And when we looked at the major non-overlapping populations, none of these clearly correlate with density. And each of them are quite variable across different tumors. So then we looked at where these cells were located. So we looked at which tissue compartment these cells are located. So across all immune cell populations, they were mostly localized into the stroma. And this was not very true, for example, for granulocytes. So they are almost evenly distributed, suggesting that these different immune cells subtypes are preferentially located within specific locations in the larger microenvironment. So beyond density, as I mentioned, immune cell spatial location can also harbor prognostic signification. This has been reported by other groups and also in our own group. So across our integrated analysis, basically most of the immune cells were located within 50 microns of tumor cells. However, granulocytes were closest to tumor, followed by macrophages and T cells. We were able to reassure our initial observations showing that M1 polarized macrophage were located closer to tumor in comparison to M2 polarized macrophages. And we are also able to see that CD8 T cells were closer to tumor than CD4 T cells. And you can see here in the image on the right where we use this metric NND to show that, yes, CD8 T cells were closer than CD4 T cells. So we next asked whether we could find recurrent patterns of immune cell infiltration across different tumors. So in this primary resected cohort, unsupervised clustering from the major non-overlapping immune cell densities revealed 4 main patterns of immune cell infiltration. 2 clusters, C1 and C2, were characterized by low T cell density and increased in immunosuppressive granulocytes or macrophages, while C3 cluster was characterized by a mix of T cells and immunosuppressive macrophages. However, this cluster 4, T cell rich cluster, was characterized by enrichment of T cells and lacking of immunosuppressive granulocytes. So using this C4 cluster as a reference, we run survival analysis, and then we saw that these 3 clusters, C1, C2, and C3, had worse survival in comparison with C4. And the survival curves overlapped a lot. So then we combined these 3 clusters and run survival analysis again using C4 as a reference. And as you can see, C4 had better overall survival in comparison with the combination of the other 3 clusters, showing that it's the combination of high T cell density and lack of immune suppressive granulocytes that is responsible for improving survival. Interestingly, when we included the neoadjuvant treated cases in this cohort, 72% of the neoadjuvant treated tumors clustered into the T cell rich cluster, the one that was associated with better outcomes. So then, to understand what was leading to this shift, we looked at each specific population. So although neoadjuvant therapy did not alter the total immune cell density, it associated with increased CD8 to CD4 ratio, decreased in immunosuppressive granulocytes, and increased in M1 to M2 ratio, a favorable combination to boost anti-tumor immune response. In addition, neoadjuvant treatment also influenced spatial distribution. This was more evident for M1 polarized macrophages. So neoadjuvant therapy was associated with greater colocalization of tumor and M1 polarized macrophages, as you can see here in the image on the left. This finding was also consistent when we used a separate metric, NND, as you can see here in the figures on the right. So we next focused on determining whether immune cell configuration was also associated to better histological response. So we assessed the histological response using the tumor regression score that is recommended by the College of American Pathologists. And what we found is that higher intraepithelial M1 polarized macrophages associated with better histological response. In addition, we also found that greater colocalization of M1 polarized macrophages and tumor cells also associated with better response, as measured here by G-cross. And this was also confirmed here, as you can see in the images. So given that higher intraepithelial M1 polarized macrophage density and greater colocalization of M1 polarized macrophages and tumor cells associated with better histological response, we next asked if this would have some impact on survival as well. And as you can see here, higher intraepithelial M1 macrophage density in the neoadjuvant treated group associated with better overall survival. And the same way, greater colocalization of M1 polarized macrophages in tumor also associated with better survival. So taken together, this shows that neoadjuvant therapy might have some effect on spatial configuration. However, if this is just, is this a cause for better response to neoadjuvant therapy or a consequence of neoadjuvant therapy, this was an open question that we could not answer with this assay. So the question that was left after our analysis was, why macrophages have specific locations? So for this, we wanted to determine what signals regulate macrophage spatial localization and organization. So this is when we used the findings that we had in the protein-based assays and moved to RNA-based assays. So we will use cosmic spatial molecular imager and profiled more than 60 regions of normal pancreas, penny, and PDAC from primary resection specimens. So here is a clustering analysis of all 250K cells. So many different cell types were identified, including macrophages and also some tumor or epithelial cells. And in addition, this analysis using cosmics also produce data, immunofluorescence data from 4 proteins, as you can see here. So we used these metrics to perform an orthogonal sanity check. So with that, we were able to see that cells that had a higher cytokeratin expression were the cells that were classified as epithelial cells. At the same time, cells that per protein had a high CD45 expression were also classified as immune cells per cosmics, per RNA assay. So this is an example, is a zoomed islet from the pancreatic islet showing cell segmentation, so color-coded here, and so showing the cell segmentation and the cell phenotypes here that are color-coded. And each of these dots represents the RNA that were measured. And here I'm just showing 5 out of 1,000 that we can profile with this assay, and showing that for a specific cell population like acinar cells, we see a lot of this RNA reg1A, and these other insulin and secretogranin that are specific for beta and delta T cell, and I forgot the name, beta cells, yes. So then what we did is that we wanted to know if the findings that we had from the protein-based assays that M1 macrophages are closer to tumor and M2 macrophages are further from tumor, if you could recapitulate here using RNA. So, and this was very reassuring because we see that as far as you go from the tumor, these markers increase. So showing that, yes, we were able to recapitulate what we saw in the protein-based space into the RNA space. Additionally, we also find another 16 other cell function and cytokine signaling genes that were differentially expressed in macrophages based on proximity of tumor. So with that, we are now helping to define or to find the signaling that is behind that differentially located cell population. So with that, having acquired all of this information from the protein-based assays, we then moved to the clinical trials. We wanted to see if we were able to, after getting all of this information for upfront resected, neoadjuvant treated but resected tumors, we wanted to see, can we see also different findings in the clinical trials? So we moved to this clinical trial that is using vitamin D to treat pancreatic cancer. I'm going to go very fast on this, but basically what vitamin D does in pancreatic cancer. So as you know, pancreatic cancer is characterized by a dense and fibrotic stroma. Most part of this extracellular matrix is produced by activated fibroblasts. Many of these fibroblasts, these activated fibroblasts, have many sources, being one of the main sources this pancreatic stellate cell quiescent, that pancreatic stellate cell. So treatment with vitamin D agonism in preclinical studies alters cancer-associated fibroblast expression programs and making these activated fibroblasts into a quiescent state. In addition, this treatment also reduced the release of several protumorigenic and immunosuppressive factors. Additionally, in cell lines, they observed that the treatment may impact PDAC neoplastic cell states into basal classical. And as you know, these cell states or pancreatic subtyping can have association with prognosis. Vitamin D can also modulate the tumor microenvironment and increasing the influx of cytotoxic T cells into the intraepithelial. And finally, they can also reduce the tumor voluming. So this is the clinical trial that we are studying with these technologies. This is a clinical trial to test the vitamin D signaling, if that could be used to improve pancreatic cancer therapy. So this is a clinical trial in metastatic PDAC. And these patients underwent two tumor biopsies before and after treatment, and they were then randomized into 3 arms. First one, gemabraxane in placebo, second, gemabraxane in paricalcital IV, and third, gemabraxane plus paricalcital oral. So this is just a study overview for this clinical trial. So basically, the tissue is being analyzed across different assays. So single nucleus, multiplex immunofluorescence, those are panels that were custom designed by us, specifically for this clinical trial, where we are assessing the vitamin D signaling pathway and fibroblast subset, and we are also running geomics. I'm just going to focus on the vitamin D panel on multiplex immunofluorescence. So this panel is very interesting because it allows us to have a general overview of the tumor microenvironment, because we are able to phenotype the main cell types, tumor, immune, and stroma. And among immune cells, we can also phenotype macrophages, helper and cytotoxic T cells, and other immune cells. Additionally, we can also, for each of these populations, we can also assess VDR protein expression at single cell level. So each of these populations can now say VDR pos and neg. So this is just an overview of VDR expression across different, or the main population, tumor, stromal, and immune cells, and showing that the expression of vitamin D receptor is heterogeneous across these populations. And as you can see, this expression is highly variable and changes among cell types, so underscoring the need of studying expression across different populations. Additionally, we will ask if VDR or vitamin D receptor expression in pretreatment samples would predict better response to vitamin D treatment. And what we see is that higher VDR expression trended to have a better response in comparison with lower VDR expression. This was true if we assess all cells, but when we stratified across main different cell types, we also saw the same trend. However, it was not more prominent for tumor and stromal cells, reassuring our hypothesis that treatment with vitamin D could make these fibroblasts less active. And finally, treatment with paricalcital trended towards increasing on cytotoxic T cells. I'm just showing just partial results here because this is this is unpublished data, but we are working on the manuscript. So in summary, tumor landscape studies with strong clinical annotation can drive therapeutic discovery by informing clinical trial design. The value of spatial tissue profiling is maximized when it builds upon existing morphology and pathology knowledge. And these technologies are complementary to the multiplex protein-based assays for tissue characterization, as I answered before. Like, this is how I see, this is how it works for us. And studying the tumors in their native microenvironment can improve cancer care. Thank you. I'm happy to take questions.
Thank you, Andressa. Are there any questions here in the hall? None. Oh, perfect.
Hi, great talk. I was wondering, was the focus on vitamin D receptors something that you were able to pull out of those initial cosmic studies, or was that more based on?
Yeah, based on the other publications. So the whole story of vitamin D is much larger than this one. I just wanted to move to the clinical trials to see that we started with resections, and then we saw some observations, and then we were able to do also some other observations in tumor immunomicroenvironment on a clinical trial setting.
Yeah, great. So I guess maybe a follow-up was some of those markers or chemokines that you saw associated with distance from the tumor. Is that something you're exploring?
Yes, okay. Yes, definitely. So these are just showing, again, partial results, but definitely. So we were very excited when we saw that beyond the markers that were in our initial assessment using protein-based analysis, we saw these other 16 other markers. So what else is there? And what you can do this? Can we manipulate some of those genes and then making M2 polarized macrophages even further from tumor? So this is the questions that we are working on now with data analysis.
Great, thanks.
That is very interesting. Do we have any more questions? I have a question of my own. So you work with what, 6 or how many markers do you work with when you're working with the opals typically?
Yeah, 8 plus DAPI.
Okay, 8 plus DAPI.
Yes.
Now, and obviously, if you were to go up, like higher, how many markers would you think, like in a panel that would ideally be able to answer the questions that you're asking beyond the 8 plus markers? Or do you think that 8 is enough for you?
Yeah, no, definitely 8 is not enough. I mean, the panels were customized by specific questions. I think they work pretty well if you want to be more granular and know not only our T cell, but what kind of T cell, what kind of macrophage. I think they are great for that purpose. But as I mentioned, like, we wanted to have everything combined in the one only, like the same panel. So what is the relationship between M1 macrophage and cytotoxic T cells that are now in different panels? So ideally, we'd like to combine the most important markers in each of these panels, and this is in the direction that we're taking now, and combine them together and see now specifically in the same tissue, in the same tissue where they are located, how they are interacting with each other. Because right now, although I combined all of the populations and I said, yeah, most of the immune cells are localized within 50 microns from tumor, but these was assumptions that I made based on assessing of each of these panels. They were not merged together.
That is awesome. So when going forward, do you envision, because pancreatic cancer really requires diagnostic advances, right? Yes. Like where you can then make sure that the patients get the right kind of treatment. Do you see this kind of a spatial scoring kind of a thing where you can get pre-treatment and analyze these kind of tumor microenvironment, put a score on it, and then perhaps identify the patients that would benefit with the right kind of treatment?
Yeah, definitely. This was true, for example, for the vitamin D receptor, using it as a biomarker, for example, or to predict better response.
That's awesome. Thanks, Andressa. That was a really good talk.
You're welcome.